Osteosignal Episode 18. This is Osteosignal with Neal D O'Neal, a podcast exploring how your body's natural design connects with osteopathic science. Translating complex signals into practical insights so you can truly thrive.
Welcome to Osteosignal Podcast. This episode, the placenta, a window into the neuroendocrine axis. So, welcome to Osteosignal, a podcast exploring how human physiology adapts, heals, and sometimes fails through the lenses of biomechanics, bioelectric regulation, and biochemical signaling. In osteopathic manual therapy, we often study disease and dysfunction, but the deeper goal is understanding how the body maintains regulation, how systems coordinate, and what happens when that coordination is lost. I'm Neal O'Neal, an osteopathically trained manual physical therapist, and with me today are Autumn Mayberry and Brent Mayberry. Autumn is hey Autumn. Autumn, you're an osteopathically trained manual therapist. Tell us about your practice.
Yes. Well, I've been studying osteopathic principles with you and our mentors for 22 years now, just barely. And I have a clinic currently in Utah, and I have when I'm there in Missouri also, I have a clinic there. So yeah, pretty busy, keeping busy, but having lots of fun, learning all kinds of new stuff.
That's awesome. And then Brent, you're here for the layperson viewpoint to help us out when Autumn and I start talking shop and don't make any sense. You're here to help us out and be understandable by all.
Yep, I'm trying to give a wider audience a little more insight and perspective into what osteopathic manual therapy can do for people, and a little more understanding into how the body works. So thanks for having me.
Yeah, perfect. Thanks for being here. Okay, so I'll say this again. One of the most powerful ways to understand the neuroendocrine axis is to look at pregnancy. Pregnancy is not simply a reproductive event. It is one of the most dramatic physiological adaptations the human body undergoes. At the end of that adaptation sits an extraordinary organ, the placenta. Today, we will use the placenta as a lens to understand the neurohormonal system, and we'll examine it through the osteosignal framework: biomechanical regulation, bioelectrical autonomic signaling, biochemical and endocrine coordination. From this perspective, the placenta becomes far more than a nutrient exchange organ. It becomes a regulatory interface between two physiological systems, the mom and the fetus. So in speaking about the placenta, most conventional descriptions define the placenta as a nutrient exchange organ, a hormone-producing organ, and a temporary fetal support structure. And those statements are all true, but incomplete. Through a systems-based osteopathic lens, the placenta functions as a dynamic regulatory interface synchronizing maternal and fetal physiology through mechanical, vascular, endocrine, autonomic, and immune signaling. It is not passive. It is a real-time adaptive control system. The placenta continuously interprets and adjusts to maternal blood flow, mechanical pressures, hormonal signaling, immune balance, autonomic tone, metabolic state. This means that maternal physiology and fetal physiology are co-regulated through the placenta. And I think one of the important one of the important things is mechanical pressures, so that not just fluid pressures, but mechanical pressures of the mother's spine, the birth canal itself as the baby is sitting there, the womb as we call it, the pressures of her diaphragm, even the pressure of her aorta on the baby. It's going to be aware of all those, and its system is adapting to what is its external environment, which is the womb. Okay, so the placenta as a biomechanical structure. Before the placenta ever produces hormones, it exists as a biomechanical structure embedded within maternal tissues. It anchors into the uterine wall, maternal spiral arteries, myometrial tissue, and the pelvic vascular basin. For the placenta
Neal, could you expand a little bit on that? What's a spiral artery? What is myometrial tissue?
Perfect.
Myo means muscle, right? And so
correct.
Yeah, maybe expand a little bit.
Yeah, we said that the placenta anchors into the uterine wall. It anchors into the uterine wall, and the uterine wall has different layers in it. One of those layers is a muscular layer, or what's called the myometrium. Okay, it also has an endometrial layer. So this placenta has to not only anchor itself to this uterine wall, but it has to start to dig through those layers in order to truly incorporate its blood flow with the mother's blood flow. And so we have what we call this process of invagination, and the placenta digs into the mother's uterine wall, and the area starts to grow, and the mother's arteries in that area actually start to open up and leak blood. And this area that the leaking of blood occurs is called the lacunae, like a lagoon. So there's a lagoon of exchange of fluid, such that the fetal circulation can get oxygen, nutrients, chemicals, some immune agents, things that it needs, and take those in, and it can dump off waste products, carbon dioxide, et cetera, et cetera. And so there's this big exchange of fluid and gases, et cetera. And that's done through the maternal spiral arteries. Now, the important thing to understand about spiral arteries, and most people don't know this, but that the arteries in the uterine wall and the arteries in the mammary glands are spiral shaped. And that is because if, let's say that they were straight and the weight of the baby starts pulling on that, or that the engorgement of the breast for breastfeeding, when the milk comes in, would pull on that straight artery, the artery would break, and then we'd have a lot of bleeding, and then that breast or uterus wouldn't be very useful. It would actually die. Not very useful when there's a placenta implanted there. So we actually, women, have these spiral arteries in their uteruses and in their mammary glands, so that when those structures enlarge, they can actually enlarge and get smaller and get bigger and get smaller and not break those arteries. So that's what the maternal spiral arteries are all about. Now, those are also the arteries that...
Sorry, I had no idea those existed. That's super cool.
Yeah, there you go.
So it allows for expansion and contraction.
Exactly. And so, yeah, it would be a real problem if we didn't have that little thing. So those are the arteries, though, that where their capillary beds become the lacunae, and that they're the ones where the exchange of gas and waste product, et cetera, and fluid, et cetera, take place. And that's also where there can actually be a mixing of maternal blood and fetal blood. And so that's where maybe stem cells from the fetus, as you had pointed out in a previous episode, defending the fetus, that stem cells from the baby can actually, and the placenta can actually get into the mother, cells can. And yes, that's where that would occur. So those maternal spiral arteries are very important, but also from a nutritive standpoint, but also from a protective standpoint of being able to get larger and then be smaller and not break and not harm the mother. Now, in the cases
of thank you for explaining that.
Yeah. Also, in the case of, say, a retained placenta, it is the maternal spiral arteries where the bleeding occurs from. So all that heavy bleeding after giving birth, it's also those same arteries because they're the ones that were attached to the placenta. Okay. So there we go. Perfect. Thank you for chiming in on that one. So also the pelvic vascular basin, right? The baby is moving. The uterus is in the pelvic basin, and as the fetus grows, it goes up out of it to a certain degree, but stays within that brim. Okay. So for the placenta to function properly, several mechanical conditions must be met. There must be adequate uterine perfusion, proper spiral artery remodeling, balanced intrauterine pressure gradients, efficient venous return, and functional lymphatic drainage. Now, the spiral arteries, as we've already found out, are particularly interesting. They remodel during pregnancy into low resistance vascular conduits, allowing large volumes of maternal blood to enter the placental circulation. This design allows extraordinary nutrient transfer, but it also means the vascular regulation must be extremely precise. We have to maintain blood pressure in there, and otherwise the placenta will dry out. So you can see that even just that control of blood flow, which is typically the purview of these sympathetics, they're the ones that shunt blood to and from. And in this case, in the uterine wall, we're talking about the mom's sympathetics, but the mom's sympathetics have to be responsive to the needs of the placenta, and the placenta will make those needs known hormonally through those spiral arteries. Also through intrauterine pressure gradients. Pressure gradient would be, and my favorite way to explain this to people is in high school chemistry, oftentimes people have seen this experiment. Their teacher will have come out and said, here's a fish tank with water in it. It's a level with water, and they'll put a semi-permeable membrane in it, and they'll pour salt on one side. And so the water levels will slowly rise on the side that has the salt in it. That would be a pressure gradient. Now, also, what we could do, so then your teacher would have pulled that semi-permeable membrane out, and the water would have leveled out, and the salt content would have evened out, and then they would put it back, and they'd say, well, this time we're going to try a different thing. We're going to put fish food on one side, and sure enough, you will see that the protein in the water draws water from the other side into it. So there's this law in physics or in chemistry that basically says, an area of high concentration will spread itself out to go to an area of low concentration. Now, if the fish food can't go over to the water will come to the fish food. Or if the salt can't go to the water that has low pressure gradient, then the pressure gradient will bring the water over to it. Well, this is the same thing that happens in the placenta. So between the fetus, the placenta and the uterus, and the rest of the mom. So you can see that you have these pressure gradients that are causing the sympathetic nervous system and the parasympathetic nervous system to change what's in the bloodstream, what's being exchanged. So it's a pretty complex system. Okay, so, and that's where the vascular regulation must be extremely precise. So those sympathetics that control that blood flow into the uterus have to be under tight control. Okay, so here's osteopathic principle number 1. Structure governs perfusion. Right? Now, normally we say structure governs function, but the function in this case is perfusion. Perfusion meaning blood flow into an area. If uterine mechanics become restricted, blood flow to the placenta can change. Oxygen diffusion may decrease. Nutrient exchange efficiency shifts. So pelvic restrictions may increase vascular resistance, altering the signals the placenta receives from the maternal system. This becomes a key clinical insight because mechanical changes can influence vascular signaling, which then influences endocrine regulation. So this is what I say this is what I mean when I say the placenta takes a hold of, or at least shares control of, the neuroendocrine system of the mother. Those mechanical changes influence what the vascular signaling is. And so that's sympathetic. And then those same chemical factors are also going to change the parasympathetic, particularly the pelvic parasympathetics, which are in contact with the hypothalamus, but ultimately also the vagus nerve, because as those pressure gradients affect the surrounding gastrointestinal tract or the surrounding tissues, the vagus nerve is also going to sense that and then make its changes as well.
Cool. I was going to ask, what are some examples of pelvic restrictions that you may have come across in your practice?
One of the most common things we see is that somebody has a hip that is stuck into external rotation. So you'll see that their feet, that one foot rolls out this way, right? And that as try as they might, they cannot get the two legs to roll in evenly. So that one leg that turns out more, my background's not helping me, those hips they won't be able to rotate in as evenly. And so if we think about the hip joint itself, there's two bones that make up the hip joint. There's the femur and the bone we call the ilium, or often called the hip bone. So that hip bone, the ilium, can be in all sorts of different positions. So part of it is the leg can be externally rotated. The ilium can be internally rotated anteriorly, rotated posteriorly. It can actually inflare or outflare. It can upslip. It can actually slide up on the sacrum and not function properly. So there's all sorts of, and it's a very, very small movement, but it is noticeable, and it's something that you can actually measure with your hands, which we do as manual therapists. We'll actually go and measure and say, well, one ilium is not moving in relation to the other ilium, or it's not positioned evenly in relation to the other ilium. And there's a test we do to decide, well, which is the good side and which is the bad side. So we push on your pelvis to determine this side's the stiff side is the bad side, or the incorrect side. So
gotcha. And then, so once you determine, or once you've observed that, then, what kind of judgments can you make about what's happening to signaling, or how is that affecting the placenta and the signals that it's getting or sending?
Yeah, that's a great question. So think about the one example that I said, well, one ilium can be kind of slid up on the sacrum, and the quadratus lumborum, which is the muscle between that hip bone and your bottom rib, and it also attaches to the lumbar spine, will then contract. Well, when it contracts like that, it's going to change the feed or the signaling of the sympathetic nervous system at T10, 11, and 12, L1, L2. Well, that's the bottom of the sympathetics. Now you've changed sympathetic tone on one side of the body and not on the other. So you have uneven signals on either side. So the body gets confused there. And in confusion, may not function as it should, or may not be able to function or be responsive to the needs of function of the placenta. So let's say that you have what if you have a right upslip and the placenta has implanted itself on the right side of the uterus? That would be a particular problem. Now, if the placenta's on the left side, that may not be as big of a problem. But certainly when those line up, and then everyone would be wondering, and you've heard, I just had a patient today say, oh, my amniotic fluid was drying up and we had to take the baby 3 weeks early. And no one understood why the amniotic fluid was drying up. Well, high sympathetic tone causes a decrease in fluid. Basically, it'll cause thick, sticky fluid, but not the serous mucus, appropriate kind of amniotic fluid that we need, and it won't deliver proper fluid out of the arterial system to keep the amniotic fluid going. So and then when, of course, I examined the patient, she had an upslip, and I worked on that, and she was like, oh, and I kind of mentioned, that's probably why you dried up, is that part of your mid back. And of course, that's just the level of the back that the diaphragm is at. And of course, every woman who's ever been pregnant knows exactly how hard it is to breathe at the end of pregnancy. Yeah.
Yes.
So,
and every husband knows too.
Right.
Yes.
Yes. So, and so there you go. I mean, that's a great question, because it just leads us into so many other aspects of understanding, like, how does this go wrong? And not necessarily from a total disease standpoint, but it does decrease the thrival of the fetus. It makes it harder for the fetus to use the womb as a safe space and a place to grow. So it has to leave early. Okay. So let's talk about
Thank you for those examples. That's great.
Okay, perfect. So let's talk about the placenta as an endocrine command center. The placenta is one of the most powerful endocrine organs in human physiology. It produces estrogen, progesterone, human chorionic gonadotropin, human placental lactogen, placental growth hormone, and corticotropin releasing hormone. Okay? Each of these hormones regulates maternal physiology in order to support fetal development. So let's talk about those. Obviously, most people know what estrogen and progesterone do. They're certainly part of the growth cycle. The fetus uses those to drive growth, right? The placenta uses them to drive growth of the baby. You think about that, think about menstruation and how there's a lot of fluid all of a sudden. And so estrogen drives fluid, and then progesterone drives fluid out. So that's how we build structures in the human body, in the fetus, and even in kids, that we actually have some cells in an area, and then we drive fluid pressure into the area to push them apart. So that's what actually drives the growth. And then the cells fill in on that form and on that structure. So that's why structure governs function. The function will be determined on how well it grew into that shape that it was supposed to. So let's talk about human placental lactogen. Not something you hear about very often. This hormone appears around 6 weeks of gestation and increases steadily through pregnancy. Its functions include increasing maternal insulin resistance. So we want the mom to be resistant to insulin. It ensures glucose availability for the fetus. It promotes fetal growth, and it prepares the mammary glands for lactation. So a pretty lactogen might make you think of lactation, but also lactation of several other things, the pancreas and the fetus. So this hormone is sometimes described as a diabetogenic hormone, meaning it intentionally reduces maternal glucose uptake so that more glucose remains available for the developing fetus. Now, that might lead us right into the question of, well, wait a second, doesn't that have something to do with gestational diabetes? Correct. If maternal metabolic buffering capacity is limited, this adaptation may contribute to gestational diabetes. And that oftentimes leads to, tells you that the mom may have diabetes down the road, or is most likely to have diabetes down the road. So women who suffer from gestational diabetes, this often reveals that they don't have as great of control of that whole system as they should. And so as they go through their life, they're going to lose function and one day be diabetic. So there you go. Something to know. So placental CRH and the HIPAA axis. So CRH, corticotropin releasing hormone, right? During pregnancy, placental CRH can increase up to 100-fold in maternal circulation. Corticotropin releasing hormone is a 41 amino acid peptide So as we've talked about in other podcasts, peptides are neurotransmitters, hormones. It's synthesized mainly in the hypothalamus's paraventricular nucleus that acts as a primary regulator of the hypothalamic pituitary adrenal axis. So corticotropin releasing hormone regulates your adrenal gland. It's also made at the placenta to help control that HIPAA axis, that hypothalamus pituitary adrenal axis. So CRH influences fetal maturation. And so, for example, an example of this is if a baby is born prematurely, one of the things they say is, oh, the baby can't breathe on their own because they don't have enough surfactant on their lungs. And so one of the things that will be done is the baby will be given aerosolized steroids so that their lung tissue will finalize in its development so that they can start breathing on their own now that they're out of the womb. So CRH also influences fetal maturation, adrenal steroid production, and the timing of labor, right? So all those things are already coming into place. They're all coming into the timing of the whole issue. And so you can see if there's some problem with that, then we're going to have adrenal problems. Okay, because CRH stimulates adrenocorticotropin hormone and cortisol production, the placenta effectively becomes a secondary amplifier of the hypothalamic pituitary adrenal axis. So, of course, CRH stimulates ACTH and cortisol production. Those are both hormones of the adrenal gland, and very important in stress response. But also, there's an appropriate stress response that people actually get stronger. You think about it as a Superman complex, we call it. Like under stress, people get big and they get large and they get loud and they get strong. And then when the stress or the stressor is alleviated, then they kind of just deflate and fall apart. And that is the action of adrenocorticotropin.
It's a hard one, Neal.
Yeah. That is the effect of ACTH in the body and cortisol. However, the problem is that when people are under chronic levels of that, it destroys their body instead of making them big and strong and then letting them recover. So the placenta makes use of this as well because that's what it uses to mature the fetus, make sure that you're producing enough hormones to actually suppress the immune system. It's one of the ways that the placenta suppresses the mom's immune system by raising these steroids in the maternal blood, and also saying, hey, when I get to a certain point, we need to mature and ripen, as it's called in the OBGYN arena. We have to ripen the cervix, right? Well, that feedback mechanism has to go back to the hypothalamus. There has to be a releasing hormone from the pituitary gland to say, hey, cervix, it's time to have this kid. Well, the placenta knows when, hey, I've done everything that I can do. Time's up. We've gone as far as we can. It's time to have this kid. Otherwise, bad things will happen from here. So there you go. Very useful. Okay, so the placenta HIPAA feedback loop. So the placental CRH, right, corticotropin releasing hormone, increases. Maternal ACTH rises. Maternal cortisol increases, which is why women will feel stressed at the end of pregnancy. That cortisol then influences fetal development and the timing of parturition, birth. This is a feed-forward regulatory system. If the maternal stress increases, placental CRH can increase further. Now, right at this point, one of the other effects is that increased stress, we might think about increased blood pressure, increased other problems. Mom's holding on to more fluid, so that's putting stress on her. She's more tired. She can't sleep. She doesn't get good rest. And so this might be start going the direction of preeclampsia. And there's more tension in the muscles. Mom can't relax. There's more pressure on her skull. She gets a little more upset easily. So you can see how, we're starting to go towards preeclampsia symptoms. And so this is a problem. So what is a normal process also starts to have little things that become abnormal that we have to watch out for. Okay. And if that environment appears challenging, the fetus may mature more quickly to improve survival outside the womb. So this is the point at which the placenta says, you know what? Mom's environment's getting too bad. I think we're going to call this now and we're just going to go ahead and have this kid out, which is part of the variability of when a child is born. Like, well, this kid's 3 weeks old and mom went through normal labor and delivery. Like she started it on her own. Well, the placenta started it on its own. Okay, so however, accelerated maturation can come with trade-offs for long-term physiological potential. And those trade-offs are that we know that preemies never recover. Whatever their birth date is, that is their going to be their true age. People have said, oh, well, if an infant was supposed to be born at 40 weeks and that was in another 4 weeks or 6 weeks or 8 weeks, then they'll just eventually they'll catch up. They'll grow and catch up. And what we found is that's not the case. Whatever time they're born, whatever they have, that's who they are for life. And it's it's one of those things where a kid has potential, has this line of potential that they can grow up. But if something happens and they come off of that and they're born prematurely, that potential then is decreased. And there's not a whole lot that medically we've seen that can change that. Now, obviously, with certain interventions, I'd like to say osteopathic manual therapy and Arbuckle's technique, where we use a cranial technique to help the brain come along, and then the baby's hypothalamus can bring it along and restore some of that potential. But for the most part, you do see that there's definitely a loss in potential function. Okay, and that would be,
it's like those kids are always on like a separate track,
right?
Than everybody else. They're just different.
They all preemies are on a different like age-related track that has nothing to do with kids that go near full term, is what we'll call that. Okay, so you can see where the problems might arise from that. So already we can see how this placenta interacts with the mom's hormonal system, and how there can be little problems at the edges because the placenta is doing its job to keep the fetus alive. It's also decreases, it's taking away from mom. And so, the system's not good enough to serve two masters perfectly. And so there's always some give and take. But if that take or that give goes too far, we can have a problem on the fetus's side, but we can definitely have problems on the mother's side as well, which would definitely lead us into postpartum depression. Okay, so let's talk more about the placenta and the autonomic nervous system. The placenta itself does not have direct neural innervation. It is profoundly influenced by the maternal autonomic tone, however. Key influences include sympathetic activity. We just talked about through the adrenal gland and blood flow to the uterus, T12, L1, L2, uterine artery resistance, so even the resistance within the arteries, and that resistance is due to sympathetic tone. It's the sympathetics that determine the circumference or the diameter of arteries. Endothelial function. Endothelium are the cells that make up an arterial wall, and they allow they either have tight junctions or loose junctions, and they allow either nutrients or oxygen or pathogens or white blood cells from the mother to escape through the endothelial wall and into the tissue behind. So, for example, during COVID, that was the whole idea about the spike protein, is that it would turn that lock, and now the endothelium couldn't keep the virus from getting through to the tissue on the backside, and that was its whole mechanism of infection, and why it would cause blood clotting, right? Because too much blood would then leak out. So you can see, well, we certainly don't want that in the placenta, and then affect the life of that placenta. It would affect the health of the baby and the ability of the fetus to grow. Okay, so endothelial function, vascular reactivity. So certainly there are a lot of there's a lot of things that the arterial system does in monitoring, just local monitoring of how much chemicals, how much carbon dioxide, what's going on in the area, and if it becomes, for example, one example in the past was toxic shock syndrome, that a woman, using feminine products would come in contact with certain products, in whether that was cotton or whether that was synthetic fibers, and it would actually cause this toxic shock where the arteries themselves, the local blood flow itself, the vasculature would heavily react and actually could cause a toxic shock syndrome, that it reacts to any toxicity or perceived toxicity and can actually cause death. Well, it'll certainly cut off blood flow. Again, not good for the mom, not good for the placenta, not good for the fetus. Okay, so elevated sympathetic tone can increase vascular resistance. And increased vascular resistance means less blood, less oxygen, less nutrients are dropped off to the fetus through the placenta. It can cause reduced uteroplacental perfusion, right? So not only does the blood not drop it off, it also changes how much blood interacts with the placental blood. So how much maternal blood, how much fetal blood interact in the placenta there, it'll actually tighten that up, because again, remember this side, the spiral arteries of the mom and the lacunae are still governed by her sympathetic nervous system. And so that alters nutrient deliveries, right? So then you don't get nutrients in, and the fetus doesn't grow. And particularly something of note is that certain cells at a certain time are supposed to grow or supposed to do something. And if that time period is missed, it's missed. There's no, oh, we'll just make up for this tomorrow. So it's very unfortunate that there, like, for example, the development of the brain. There are certain cells that are supposed to move at a certain time. Otherwise, something happens, like, for example, a wall is put up. And if those cells hadn't migrated through that area, they can't get there. Another thing would be, like, say, the kidney. The kidney starts on the bottom of the diaphragm and is actually attached to the top of the pelvis and goes with the pelvis. Well, there's a point of time where the kidneys are supposed to get the kidney. It's one kidney at that point. It's more like a pancake. That kidney is supposed to get a signal that breaks it apart and causes it to turn, so that then it can stay higher up in the abdomen and not follow the pelvis. So there's something called a horseshoe kidney, and it will be stuck to the bottom of the pelvis and not be up here by the diaphragm where it should be. So problematic. And those things, when those signals are supposed to occur, if they don't occur when they're supposed to, and too much time elapses, the ability to do that change in function is gone. It's lost. So that's very problematic. Okay, chronic autonomic rate dysregulation may therefore influence placental efficiency. Let me say that again. Chronic autonomic dysregulation therefore influences placental efficiency. Parasympathetic influences, particularly through vagal regulation and S2 through 4 pelvic parasympathetics, also influence trophic processes. Trophic means health and nutrition of tissue. So, for example, if somebody has dry skin that has little scabs on it, you'll see people with little problems with their skin. That's a trophic, that's a poor trophic change in the skin, poor health of the skin. So these processes such as tissue growth, nourishment, and development won't occur. Well, that's very important in a growing fetus, a rapidly growing fetus. Okay, osteopathic principle number 2, autonomics govern vascular tone, right? We said this already, but bears repeating. Sympathetic segments, T10, 11, 12, L1, L2, influence uterine blood flow. The entire, so part of the midgut, the midgut is influenced through T10 and 11, and the hindgut through T12, L1, L2. But remember, there's various parts to that uterus, and it's getting control of blood flow from multiple segments of the sympathetics. Okay, so facilitation in these segments may increase uterine artery resistance, contribute to placental insufficiency, influence patterns seen in preeclampsia, just as we were saying. And so that's really the problem. And again, remember, these are the levels that are the level of the kidneys, the level of the adrenals, and the level of the diaphragm, right? So this whole low thoracic, upper lumbar, low thoracic area. And so that's particularly problematic, especially considering that every pregnant lady you've ever seen has this very large protrusion on the front of their abdomen, which causes them to really arch at just about those areas, which is in and of itself a form of facilitation, if you will, which is an osteopathic term saying the area may not work, the nerves won't be responsive as they should be. Okay.
All right, I was just gonna ask you, what is facilitation? So it means you said one more time, it means that the nerves don't function the way that they're designed.
You're right. So their ability to do feedback. So all nerves operate off of a reflex loop, and we take sensory information in, and then that sensory information goes to the spinal cord, and now actually on its way, if they're sympathetic nerves, then they go to the chain ganglion. The chain ganglion make decisions on, hey, this information is coming in. Here's what I think I should do. I should pass that information here, or I should tell this artery to tighten down, or I should tell this gland not to produce something. Well, what if that occurs normally on one side of the spine, right? But then on the other side, so there's this reflex that goes in. Information comes in, a neuron makes a decision as to what should happen, and then there's a quick reflex out while the information travels up to the brain, to the hypothalamus. So that quick, more local reflex, is the normal function. But what if there's some irritation at that level, such that neuron has either become hypersensitive, so that it responds too quickly to make a change, and particularly sympathetics are going to shut down blood flow. They're going to shunt blood away. Well, we don't want to shunt blood away from the placenta. This is a time when we don't shunt or shouldn't be shunting blood. But if those levels are facilitated, they're irritated, and so they might be hypersensitive and do something they normally wouldn't do. Or they're facilitated in such a way that they don't do what they should do. For example, they should say, hey, we want to cause a little bit more sticky fluid in this area and cause the immune system to be a little more touchy because we've got the placenta, and maybe mom has a has a sinus infection, or she has a bacterial infection, or maybe she just has some yeast or whatever floating through her body, and the sympathetics should be killing that, but they're not as touchy as they normally are, so they don't react. So you can see how that facilitation means you just don't get the proper response in that feedback loop, that reflex loop. Okay, so yeah, so that's a facilitated segment. Those are segments that don't work properly. Okay, the pressure gradient model. So we're going to talk about pressure gradients. Placental exchange depends on pressure gradients between several compartments: the maternal arterial inflow, the intervillous space, the fetal capillaries, and the maternal venous return. So let's draw the picture. We've already talked about the maternal spiral arteries and how they come in, and then they come to these capillary beds, and in those capillary beds you have lacunae, and lacunae are these lagoons that they are leaking blood into the area. Nice oxygen-rich, nutrient-rich blood. It's flowing into the area, and there's these villi, right? So the placenta has these villi that come into the lacunae in order to interact with that blood and to pull those across its membrane. Now, generally, those villi, like small finger-like projections, they're just absorbing across their surfaces. Now, it can be that larger structures can get through there, like a stem cell, like a maternal cell. Immunoglobulins will get through there. So all this, the lacunae are there, and the little villi are in there, sucking up nutrients, sucking up oxygen, taking in all this good stuff, and then they're bringing that through the fetal capillaries. So now you come through the placental blood flow, down the placental artery and vein into the umbilicus or belly button, right? And then there's one artery that goes up towards the liver and one artery that goes down to the bladder. And then of course there's two veins that go with those. Veins have oxygenated blood and the arteries have deoxygenated blood. And so that's where the fetal capillaries then pick up that blood flow in the bladder and in the liver. So and then the blood flow through the fetus is actually going backwards. So how blood normally goes through the right heart to the lungs to the left heart and out to the body, instead what it's doing is it's going backwards through the left heart to the lungs, through the right heart. In fact, there's a shunt across the two sides, so it's really kind of skipping the lungs unless the lungs need oxygen for their own cellular purpose. But since you're not breathing with them, or the fetus is not breathing with them, you're not really shoving all the fetal blood through there. So those fetal capillaries in those two areas where the fetal veins come in, or the placental veins come in, they're sucking up all those nutrients and they're transporting it across, and they're doing their part to do an exchange. So it's a little bit complicated there. So pregnancy drastically changes mechanical pressures in the body. So if there aren't appropriate pressure gradients, nutrients and ions and proteins and oxygen do not get driven across those structures from one compartment to the next. They'll just stay where they are. It's easier for those molecules, or those molecules really to stay where they are than it is to be driven across membranes and then to go into these other circulations. So that pressure gradient model has to be really high at the maternal end so that you can get it into the fetal end. The problem is what if the maternal end drops because of her sympathetic tone or because of some other problem going on? So pregnancy really dramatically changes mechanical pressures in the body. These include increased intra-abdominal pressure, diaphragm elevation, pelvic venous congestion, and rib cage restriction. So all those things that normally help the mother pump blood, pump oxygen, or pump air to exchange oxygen, they're all challenged in this situation. And the closer the fetus gets to full term, the more mom is challenged. So it makes it even more difficult. So you can see that those pressure gradients have to be finely tuned. And so what the placenta does is it uses all those chemicals at its disposal, all those hormones, to loosen up mom's system so that mom's system dumps towards it even more, to raise those pressure gradients, to drive oxygen, to drive nutrients, to drive ions towards the fetus. If these pressure relationships shift, the placental exchange efficiency drops. Well, it'll change appropriately, and usually to the bad, which is not something we want for the fetus. So certainly when, right, and Autumn, you deal with a lot of kids. I mean, you've seen this.
Recently, yeah. We had a mom that her baby was, on schedule at 20 weeks, and then all of a sudden it picked up speed and it was really big all of a sudden. So I hadn't realized that it could just say, I can tell the container mom isn't doing very well, so I'm going to develop more quickly. But that's what we saw is he was at almost 36 weeks and he was already 7 pounds. And so she was, in a lot of distress. And the doctor was like, we need to have the baby as soon as possible. But he's like, legally, I can't induce you or anything. And I said, well, let's just get everything, straight and loose, mobile so that things can get into a good position. And she was in labor, 6 hours labor later, had the baby within 25 hours. So, but then, the baby had some issues too. You could tell his physiology had adapted to kind of help support the mom a little bit, and was under a lot of stress too. So he had, some jaundice. And so we, got the pressure. When you looked at the baby, we kind of dressed him down. You could see different colors above the diaphragm as opposed to below the diaphragm. The capillaries weren't the same color. It was a little bit more purple and a little bit more blotchy on one side or one end. And so we were able to get the diaphragm and those other structures to move and take that pressure off. The kid could breathe better, and the baby could breathe better, and mom could breathe better. And she started to get a lot better. But the baby did pick up a lot of stuff from the mom and her stress.
Exactly. So yeah, you've described it perfectly. That's exactly what we see going on. And you did exactly what an osteopathic manual therapist should do. You went back and looked at those systems and said, look, the increased abdominal pressure, intra-abdominal pressure, how do I decrease that? You make it so the diaphragm can drain. You make it so the lymphatics can drain better. Diaphragm elevation, you also make it so that that the pelvic floor works with the diaphragm so that you get more of a full pumping, as opposed to the diaphragm just having to lift farther and farther up in order to get a breath. You actually want the entire container to move so that the mom can get a better breath and get more oxygen and have pressure gradients. And then, of course, pelvic venous congestion, make sure her pelvis works, like you said, make her pelvic floor work, all those other things you were doing. And then, like you said, worked on her rib cage and made sure that those ribs all worked, her sternum manubrial, just does everything. Can she fully breathe and fully exchange gases? Perfect. Exactly. And then like you said, the baby was already changing and becoming ready for birth at an advanced rate. Okay. So let's talk a little bit more about that, the mechanical vascular endocrine loop. So for example, restriction of the respiratory diaphragm, you get impaired venous return, right? The inferior vena cava that is taking venous return from the entire lower body has to go through the right side of the diaphragm, not too far from the spine, but a little bit to the right. If that diaphragm can't move appropriately, the diaphragm can't relax such that it allows venous return to the heart. And that inferior vena cava goes straight into the right side of the heart. So very important. Increased uterine venous pressure, right? If the uterus has increased venous pressure, then it takes even more arterial pressure to push blood into there. That's a real problem because now, just like with any artery, you can blow arteries, and we don't want to be blowing arteries or get a placental infarct. That can be very deadly. Uterine infarct is going to affect that placenta. A placental infarct is really going to be harmful to the fetus. So bad things happen when you have increased uterine venous pressure. Spiral artery stress. If those arteries are under stress, that increases the blood pressure. Altered placental signaling. If the placenta if the placenta is under distress, it's going to be stressed. It's not going to be able to commandeer mom's neurohormonal axis effectively, and the fetus is going to suffer. And endocrine shifts, right? The mom is going to shift her endocrine system. So if mom is too stressed, or mom is not in thrival mode, if she's more just going back to survival mode, the fetus is going to lose out. So all very bad things. So small mechanical changes can therefore amplify systemic signaling changes. This is one of the fundamental principles behind Osteosignal framework. We're looking at signals in a systems approach. We're looking at these signals and how they go back and forth. And our job is to clear the pathway for the signals. So instead of, people say, oh, well, you kind of massage stuff and rub it. What can that do? It's actually very powerful because we're changing endocrine signaling. We're amplifying the systemic signaling changes. So very important. And it doesn't take massive changes to cause that.
And it's carefully applied in a really precise way. And in a precise order too. Like we build adaptability back into the system so that there's somewhere for that fluid that's built up to go, for example, or, that you can get that, the oxygen exchange and those fluid pressures and stuff to even out. So it's not just rubbing, willy nilly and just trying to calm things down. There's a lot of training that goes into it, that you have to understand that helps things go so much better.
Exactly. And that's systems analysis, like understanding the entire system. And this is one of the places that, this needs to be this is adjunctive to medical treatment. Right. I mean, we need the doctors, doing their job, but there needs to be more people like us who are helping patients. We make what we don't do what the doctor does. We make what the doctor does work better.
Yes.
Right? Or we're not doing the placenta's job, but we make it work better. And that's the whole thing, right? BSFF, there was an old commercial that said, we don't make the things you use, we make the things you use better. And that's us. That we make everybody work just a little bit better so that everything's a little more efficient, that there's less stress on it, that there's not so much pressure on these things, and everybody benefits from that. The mother benefits from that, the placenta benefits from that, and the fetus benefits from that. And so I don't think many people understand that, hey, as an osteopathic manual therapist, one of the things we do is we treat the placenta. I have placed my hands on a womb and helped get the congestion, that venous congestion, that uterine venous congestion. The uterus itself needs treated very gently, but in a way that reduces the pressure volume in that uterus so that it can be responsive, so that it has room to absorb arterial flow and get rid of venous flow. It can move. That mom can breathe because now the uterus is not a solid, hard mass that won't move. It becomes a little more supple and allows more motion. That allows the diaphragm to move. That allows the pelvic floor to move. That decreases the stress in the system, et cetera, et cetera, et cetera. So exactly as you say.
And then all those signals get where they need to go. And then things are, the ability to do it right is in there. It's just like roadblocked, and we just get rid of those roadblocks and help it to the signals to get where they need to go.
Exactly. Okay. So that leads right into our next point, the placenta as an immune regulator. Another remarkable function of the placenta is immune modulation. Because the fetus contains genetic material from both parents, it could theoretically trigger maternal immune rejection, right? The placenta prevents this by shifting immune balance through hormones. It promotes a transition from Th1 dominant immunity. For those of you who are immunology nerds out there, we do talk about this in when we are discussing immunology. I won't discuss exactly what a Th1 dominant immunity is, but it changes Th1 dominant immunity towards Th2 dominant immunity, reducing inflammatory rejection responses. Really, that's what we want to know, is it changes you from being so sympathetically ardent about killing things and being more, okay, look, long term we'll let this go. Okay, placental stress or dysfunction may contribute to conditions such as preeclampsia, intrauterine growth restriction, right? A big problem. Preterm labor, all things that send people to the doctor, and all sorts of reasons that doctors say, now let's take this kid now, it's getting too dangerous, or require further medical treatment. And if we can minimize that need for that treatment or head it off, that would be even better. Immune balance during pregnancy depends on adequate perfusion, stable autonomic tone, low inflammatory burden. So making sure that the sacrum works, making sure that the vagus is responsive, making sure the cranial base works, making sure that the hypothalamus is, and the thyroid and the adrenal and the gonads are all responsive to, but able to do their primary function for the mother while also being available for doing the work for the fetus. Okay, our next point is placental and metabolic signaling. Placental hormones also regulate maternal metabolic allocation. Human placental lactogen increases insulin resistance, so glucose remains available to the fetus. If maternal metabolic reserve is insufficient, gestational diabetes risk increases. Cortisol-insulin interactions intensify. Endothelial stress rises. So we kind of know about gestational diabetes, but cortisol-insulin interactions, the cold cortisol insulin interaction, one part of that is the adrenal gland. If you start having a low blood sugar as a person, your adrenal glands kick in and they force the liver. There's a reflex from the adrenal glands to the liver to say, hey, start kicking out glucose. Now, the liver doesn't like to be told what to do because it's basically keeping in mind, it's monitoring the whole system and saying, well, all my input says I should hold on to this glucose and only release it at a small amount because we don't need it for anything. We need to think about tomorrow. We need glucose for tomorrow to keep us alive until our next meal. So I'm only going to parse out this glucose at every so little over time. Well, in enough of a stress situation, the problem is that the adrenal gland will start hitting this reflex saying, kick out the glucose, kick out the glucose, kick out the glucose. And now instead of the liver being able to regulate glucose, what happens is now it's out in the body. And the body's going to say, well, I guess we'll turn this into fat, or or mom's getting a high blood sugar. And so that starts causing problems. So you get this gestational diabetes of high blood sugars. And then, of course, that has its own, causes its own set of problems off into the diabetic world. So you can see how this cortisol-insulin interaction, we don't want that to intensify. We want that to be as tight as possible, just nice and smooth and well modulated, working well. We don't want that to be jaggedy and not responsive. So from a systems perspective, the placenta is directing the distribution of metabolic fuel between two organisms. So the placenta should have a nuanced enough approach to be able to make sure there's enough blood sugar for the fetus, but that once the fetus stops taking that, that then it doesn't overforce the adrenals to cause the liver to release too much glucose. Otherwise, you have excess glucose laying around, and that's maternal or gestational diabetes. That's problematic. Okay, so as long as that
and then after the mother has the baby at that point too, then a lot of times after delivery, we see like gallbladder issues and all kinds of stuff, and on top of like blood sugar issues as well, just because that liver's been overworked. And
yeah, you see all sorts of GI disturbances and all sorts of metabolic disorder. I mean, metabolic disorder of all sorts will pop up, which is often, what happens with women. They'll say, well, I was fine through this, then I had my kids, and then somewhere shortly after that, this happened. Say, well, after 3 kids or 5 kids, or depending on however many kids, and of course you want to ask your patient, tell me about those pregnancies. Let's go through these. I said, well, I had gestational diabetes with this one, but okay. Right, which is what you're talking about, right? You see this all the time. Okay, osteopathic systems integration. From an osteopathic evaluation perspective, several structural regions influence placental physiology. The thoracic inlet. The thoracic inlet regulates venous return, lymphatic drainage, and endocrine clearance. Basically, all of the lymphatic drainage of the body, 3/4 of the lower body, the somatic system, all goes through this left thoracic inlet. The left head and neck come down through this left side. The organs all drain through the right side. So the area above the liver on the right, somatically, and the right head and neck drain into the right side, but also the heart and lungs drain into this right side. And you also have the lymphatic drainage of the organs drains into this right side. So you have a ton of lymphatic drainage in this area. So if the thoracic inlet, or what some people know as the thoracic outlet, doesn't function correctly, then that lymphatic drainage has to come up and over this first rib and get down into the superior vena cava and into the heart ultimately. And then that's how it gets into the bloodstream and then gets processed by the kidneys, etc. So restriction here may elevate venous pressure and indirectly influence uterine perfusion. Again, not good. Respiratory diaphragm. The diaphragm acts as the primary venous and lymphatic pump, right? So again, if that respiratory diaphragm doesn't have good excursion, if the rib cage doesn't have good front to back volume, side to side volume, the respiratory diaphragm cannot function fully, and may have to fire more often, or will fire more rigidly, and that causes problems. That those restrictions may lead to impaired pelvic venous drainage, right? If the respiratory diaphragm is not pushing on the pelvic floor diaphragm enough, you don't push fluid out of the pelvis. It will increase.
And this, I just thought of this too, as years ago, I remember we were talking a lot about HRV. And this is a lot of things that if your HRV is not normalizing and you've been through this situation, this is a lot of things it's picking up on.
Exactly.
This venous exactly problem and
hey, your
diaphragm problem.
Right.
Yeah, and I know. I remember. I was paying attention.
All right. Perfect. So if the diaphragm is restricted, that restriction may increase congestion throughout the body. Not good. How many pregnant ladies towards the end of term do you notice that are pretty darn swollen? And that's not good for their veins. That's not good for several structures. It also alters intrauterine pressure relationships. Again, back to those pressure gradients. If you can't control the pressure gradients, then you can't maintain health and thrival of that fetus. So pelvic diaphragm. The pelvic diaphragm directly influences uterine mechanics. Is the uterus supple, as we spoke about? venous pooling in the pelvic floor, and pressure gradients within the pelvis itself, which are going to affect the pressure gradients within the uterus and the pressure gradients within the placenta. Finally, the thoracolumbar junction. Sympathetic regulation from T10 through L2 influences uterine vasculature, ovarian blood flow, right? Because we still need mom's estrogen, renal circulation. Oh, renal circulation. The kidneys come into it. Oh my gosh. Yeah, the kidneys are highly, highly important for their ability to filter the blood and maintain blood pressure, because blood pressure through the mom's system is maintained through kidney circulation. And do those kidneys, get plenty of blood, and are they able to filter that blood appropriately? So facilitation in this region may contribute to hypertensive pregnancy patterns. Okay. So moving on to placental disorders through a systems lens, right? We want to see what are the things that go wrong with placentas. When placental regulation is disrupted, several clinical conditions may emerge. Placental insufficiency. Associated factors include impaired perfusion, increased vascular resistance, autonomic imbalance, mechanical restriction. So placental insufficiency may also include, like, for example, placenta previa or placenta abruptio, where the placenta actually starts pulling loose from the uterine wall. That really stops the whole process. Preeclampsia often involves abnormal spiral artery remodeling, endothelial dysfunction. Remember, those are the cells that line arteries. Placental stress signaling, so the adrenals. Maternal vascular reactivity, right? How's the mom's vascular system respond to what the needs of the placenta are? Gestational diabetes, driven by placental hormone-induced insulin resistance, limited maternal metabolic reserve, cortisol interactions, and a few other things, right? But obviously, and we just spoke about gestational diabetes. Okay, so osteosignal summary model. From the osteosignal perspective, the placenta functions as a biomechanical interface, an endocrine amplifier, an immune regulator, a metabolic controller, and a stress sensor. Its function depends on pressure gradients, vascular compliance, autonomic balance, endocrine capacity, and structural freedom. All things that osteopathically, we as manual therapists we work on. We work on all those things. Do the pressure gradients, are the pressure gradients available on various levels, as we just spoke about? Vascular compliance, that's a big part of what we do. Autonomic balance, everything from vagus, S2, 3, and 4 in the sacrum, to the sympathetics. Endocrine capacity, how does the mom's brain, hypothalamus, pituitary function so that it's responsive to also the needs of the fetus through the placenta and her own needs as that neuroendocrine axis is being challenged through the placenta, right? And structural freedom, you still have to make sure that mom's body works, as well as it possibly can to allow her to function while also having this very large apparatus in her abdomen. Okay.
Neal, I was just going to ask if you could just elaborate a little bit on what a biomechanical interface is. Like, I'm trying to think of what the placenta would do to be a biomechanical interface. Could you maybe remind me what that is?
Yeah. So basically through the uterus, right? So it attaches itself to the uterus, and that biomechanical interface, there are 8 ligaments that hold the uterus in place. 2 go to the pubic symphysis, 2 go to the sacrum itself, 2 go to the ilia, and then you have your broad ligament that goes up to T12, T10, 11, 12, to a structure that the structure that grows the pelvic organs is known as the gubernaculum, and the gubernaculum grows down the front of the spine and then helps make these organs. But it goes away after birth, but the mother still has this support ligament, if you will, or this support structure called the broad ligament. So that broad ligament actually attaches to the front of the spine and the diaphragm. And so that placenta with its fluid pressures, remember, now it becomes a fluid pressure device. And in order to truly understand this, and I this is an example I use for students all the time, is that, we think about our muscles and we say, oh yeah, we are muscles and they have actin and myosin and they pull, and then my arm moves like this. And while that is a description, it may not be fully accurate. One way to understand how a muscle functions is that, remember, that muscle is in a bag, and the bag happens to be attached to two separate bones, separated. And then what happens is that the muscle fiber actually balls up in the center of that bag, creating fluid pressure. That fluid pressure then changes the length of that bag so that pretty soon the arm is flexed. Let's go to a placenta. The placenta is its own contained structure that can increase its fluid volume, thus creating pressure or tension that will then pull on the uterus. The uterus is in its own bag, and it's supported by several structures that pull on mom's, her biomechanical system. So let's say, for example, I have one hand at the T12 area and one hand on the pubic symphysis, on the backside of the pubic symphysis where these ligaments go, and I'm trying to release the tension in those by lining up the forces, or I have one hand on there and I actually gently place my hand on the uterus and move it around so that that you feel a decrease in fluid tension. That's how the placenta would be a biomechanical force, would create a biomechanical interface, right? Its fluid tensions change the fluid tensions of the uterus, and the uterus is attached by ligaments to the body, and those body parts are going to then change their orientation to each other, just like we do it in an arm or biceps with the elbow or with the forearm and the shoulder. The spine can move. Let's say that placenta is on one side of the uterus, which, depending on where it may be creating more fluid pressure on one side of the body, and the mom may develop somewhat of a scoliosis through that. And then when mom gives birth, is mom still stuck in that scoliosis because she was there for so many months? So you can see how that's a biomechanical interface. It can cause biomechanical problems. Yeah, right. It kind of makes sense once you understand that how muscles, what do muscles really do? Well, they actually change the fluid tension in the bag, and anything that can change fluid tension in a bag can then direct force through those fascial and ligamentous structures. So there you go.
Cool.
A different way
thank you for doing that.
Yeah, a different way to think about it. Not something that's not how they describe it down at the gym, right? When we're lifting weights and stuff. So, they say, oh no, it's actin-and-myosin and cross bridging. But understanding that it's fluid tension that does that, and that's how the placenta would be a biomechanical interface. All right, so the placenta is not simply, so probably the core teaching thing here that I really want to get across is the placenta is not simply supplying nutrients to the fetus. It is synchronizing two regulatory systems through blood flow, through hormones, through immune signaling, and through pressure dynamics. So it is a very dynamic, intelligent structure. When structure compresses regulation, placental signaling shifts, right? When the mom structure compresses that regulatory ability of the placenta's signaling will shift. And that shift can influence the health of both the mother and the developing child. So in closing, I just want to can recapitulate that understanding systems like the placenta reminds us that physiology is not isolated. We see this mother or this person and her neuroendocrine axis and how it functions. And we have these ideas about, it should just function like this and it should work perfectly. We bring the placenta in and it reminds us that, look, physiology is always a dynamic equilibrium. Things are constantly moving back and forth. By adding this placenta in and changing the center of, or the center of control here, the center of regulation, all of a sudden we see how that neuroendocrine axis may not be as responsive as it needs to be, and we see where it breaks down. We see the edges of its function and how it can function and how it can help regulate physiology in the mother, in the placenta, in the fetus. And that we see that mechanical forces influence circulation. Circulation influences endocrine signaling. Endocrine signals shape development. And this is precisely where osteopathic manual therapy can play a role, not as a replacement for medical care, but as an adjunctive, as a method of restoring structural freedom so regulatory systems can function as designed. Because when the body can adapt, it can survive. And when regulation is optimized, it can thrive. And that's just a really important concept for everyone to understand. I think it's an excellent lens for us all to kind of be able to look at a body that's without a fetus in it, how it should act and how it should be able to be self-regulatory. And that's what we see, breakdowns in self-regulation. All right.
Yep. I just want to say too, like when I did my master clinician test a couple weeks ago up with you, and we were talking about how the placenta, kind of inserts itself and can shut down, other endocrine organs and things. That was really enlightening to me. And it's been amazing how being able to understand and talk about that with you then. And then we have this pelvis class last weekend. And then, where I'm even in situations where you don't have the placenta, but that talking about how, those organs have their different things and how they can kind of step over each other. And then they have to have these systems talking back and forth. It's been able to help me do a lot better with even my postmenopausal patients, where their hormones are fluctuating and their organs are shifting, and to be able to say, well, this wouldn't be here. And, and just be able to think that through has been a huge, huge help, even just in the last couple of weeks since talking about that. So anyway, that was really it was neat to be able to take the test, but it was also neat to be able to learn, higher things than what I've figured out before. And I'm really glad we're talking about this as a lot of people, because there's so many, almost half the population, right, that is possibly in this situation or has been. And it helps, you can do a whole lot more for yourself if you understand what's happening, and then there's something you can do about it. And it doesn't have to be super invasive. And like you said, with medical things, they do what they do well, and we do what we do well. And, they do go hand in hand if people know about it and can opt for that kind of care. So it's really
right.
cool.
And hopefully more manual therapists see this, hear this, and say, I want to be able to do that. We would love to have those people come. And there's lots of information out there. There's lots of osteopathic. There's lots of manual therapy stuff about this. We certainly have our brand, but I would like to think that we have a pretty high level brand of education and intelligence towards treating these problems. So I would encourage people to come and take part in our
education. Come to class with us.
Exactly. We have a good time. We talk about goofy.
Yes, we do.
We're total nerds. We nerd out on this stuff. So
I got to tell you too, I had a patient, my very first one this morning after classes last weekend, and she came in and I hadn't seen her. She travels a bit. Hadn't seen her in a bit. She said, well, I'm coming back because that back pain, my lower right back is really painful again. And I was like, that's because you got an ovarian cyst. And she goes, I was just in the ER last night and they found an ovarian cyst. So I was like, yeah, but the way that when we study these things, you're like, oh my gosh, she hadn't even laid down the table yet. And I'm like, I already know what I'm going after, So but she appreciates that too. Instead of, I went to the ER and then they found this thing, but I'm not feeling any better. And the biggest thing that I realized that was really cool to see after her treatment today was not that she could walk better because her back felt better, was that she looked rested. That was the biggest thing that I noticed, is she looked like she had the ability to heal and kind of spring back from things instead of it just being, shut down and be like, this has been miserable forever, But that was her affect was so much more helped by even in their walking. She didn't have pain, but that wasn't the most impressive thing, I didn't think. So
yeah, no, immediately her ability to regulate her cortisol levels changes. That's amazing.
Yep.
That's amazing.
Yeah. So thank you for your classes. It helps lots of people. So yeah, if you're training this at all, yes, please come to class. We would love to have more. So
all right. Yes, that would be awesome. So thank you for joining us today. And if you'd like to hear more, check us out on pursuitpt.com or wherever you've received this podcast. Thanks for joining me today, Autumn and Brent. And we'll see you next
thanks,
time.
Neal. All right.
All right. Thanks, Neal.
Thanks for joining us on another episode of Osteosignal with Neal D O'Neal. For more information, please visit pursuitpt.com or pursuitperformancetraining.com. Want to show your support for the podcast? Give us a like, click subscribe, and leave a comment or review. We appreciate it. Our music was written and performed by Sky Toes. Copyright 2026 by Neal D O'Neal.